And next up is Dr. Julian Midgley. He is a pediatric nephrologist at Alberta Children's Hospital in Calgary, Canada, and a professor at the University of Calgary. He's the past president of the Kidney Foundation of Canada and is also a member of CRF's Medical and Scientific Advisory Board, and he sees many cystinosis patients in Canada. Welcome, Dr. Midgley.
Thank you very much indeed, and I'm very pleased to be here again, meeting lots of old friends and some new families as well. So I'm going to talk a little bit about the changing face of cystinosis from childhood to adulthood, and I'd just like to start off by showing the fact that the Children's Hospital in Calgary is a very nice place. There's blue sky, there's green grass. Actually, it's a little bit more like this because it's been snowing very much in the last couple of days, so there's about a foot of snow there. So although it may not seem very warm to most people here, it's, yeah, it's better. So in Calgary, we've seen quite a few patients over the years. At the moment, we're following more adults, many more actually, 13 adults and only 7 children with cystinosis. They haven't had a new diagnosis for several years. We've had quite a few adults who've come to the clinic as an adult not being diagnosed. So we've got a lot of experience in seeing kids, and when you think that BC and Saskatchewan perhaps have only got 1 or 2 patients, we're not quite sure why there's so many patients in Calgary, and we continue to see the adult patients, even though some of them have been transplanted. So I'm going to talk a little bit about child to adolescence, quite a bit about medical issues, a little bit about adolescence to adulthood, and a couple of items regarding adulthood. And in the top right corner, we've got a little box which will talk about some of the things that we monitor and what and how frequently, and I'll come back to make a comment about that in a bit. So we've heard a lot about cystinosis and growth and such like and so forth, and G-tubes. It's always interesting to know when to remove a G-tube. I've got a couple of boys there showing off their scars. Perhaps a little later than earlier is the best time, but you need to be taking pills. Make sure you get your calories in somehow, and water. Some kids are quite attached to their G-tubes. Some really want to get rid of them. But in my experience, teenage years or perhaps a little early in some. Height continues to be a slight issue. We've got a graph here which shows that the growth is quite a lot under the curve, but gets closer and closer. Growth hormone often around about school age when it becomes more obvious that children are short, but growth is a little less of an issue, especially with growth hormone as you move into the adolescent years. The kidney we've heard a lot about today. We've got that nephron that nephrologists like so much. But the Fanconi syndrome continues. And paradoxically, even though as the kidney function decreases over time, and therefore there's less being filtered, that's the green arrow, out of the blood into the tubule, the amount that's reabsorbed, the blue arrow, doesn't really balance as well. So even though you've got less filtration, the reabsorption can become more of a problem. And some of the older patients and adults in their 20s with native kidney function require actually more electrolytes, especially bicarbonate and citrate. And then when you move to an adult nephrologist, perhaps they'll say, gosh, you've got really bad kidney function. We really shouldn't be taking that potassium and phosphate, but in fact, potassium phosphate may still be needed, even right up to very end-stage renal disease, which makes the adult nephrologist freak out a little bit. And then that yellow bit, that urine, continue to be relatively high. And sometimes you may have some bladder dysfunction if you're emptying your bladder quite properly. And this use of indomethacin and ibuprofen, occasionally adult patients may actually benefit from these medications for a period of a few weeks to re-establish their concentrating ability, because they start to get an excessive amount of urine, and you can actually dial that back a little bit. So what about that urine output? Well, I said, gosh, yeah, 4 litres perhaps. Well, I looked at the last 24-hour urines on 7 adult patients, and the average was 6.3 litres. Now, that's 1.5 US gallons, and the range is 1 to 2 US gallons there of urine output. That's a lot. So that urine output is maintained. And when you have a transplant, you can still be peeing that amount, even though your GFR, the kidney function, isn't very good. And when you have a transplant, you're supposed to stay hydrated, and if you're peeing so much, that's not going to be so easy. So early removal of the old kidneys after transplant should really be something that should be considered quite carefully, although it's not always needed. And if you can avoid episodes of dehydration because of the native urine output, you can get rid of that acute tubular necrosis, which those transplant nephrologists don't want. Proteinuria continues and may actually increase. So the amount of protein in the urine may be controlled by an ACE inhibitor, although we've heard from Larry that that can be a little bit controversial. That 6-day protocol is very much needed. But substances are bound to the protein, such as copper, iron, vitamin D, and other things. And cysteamine actually chelates copper. So we measure copper levels on a yearly basis and may ask patients to take some multivitamins with copper to try and get those copper levels back up. But iron and vitamin D may be more of an issue than you think because of that loss in the urine. So this kidney survival is an interesting thing, and when cysteamine became available, you could see that the survival of the kidneys, as depicted by the red arrow, moved from about 10 years average survival up until 18, 19 years of age. And this is the representation of how cysteamine is good for keeping kidneys in place for longer. On the top there, we've got a little signal that perhaps in the 2000s, kidney survival might be even better, although the curves overlap quite a bit, but there's just a signal there. This kidney survival is partly related to how early you can start cysteamine, but when the diagnosis is made, you can't really do anything about going back and getting cysteamine in early. But keeping the white cell cysteine level lower rather than higher appears to be helpful. Now this graph, the lowest on the right there, the lowest cysteamine that was white cell cysteine level that was looked at was less than 1.2. It might have been interesting to look at values of less than 1 or less than 0.8 to see whether or not there was a further benefit to having white cell cysteine levels lower. So I looked at the survival of kidneys in our 14 children that we've looked after since diagnosis. And you can see that the median kidney survival in those 14 children is actually 24 years, and there's a couple of 29-year-olds who haven't needed dialysis or a kidney transplant yet. And I think that the lower the white cell cysteine level, the better, and we tried to get our white cell cysteine levels below 1 for sure. So the message that I'd like to talk a little bit about now is that for kidneys, and probably certainly for non-kidney issues, almost certainly adherence to cysteamine is important, and I believe that the lower the white cell cysteine level, the better. But that's an awful lot of pills over a long period of time. So I'm going to mention a few other organs, not all the organs that are affected, but some of the ones that seem to be perhaps more of an issue or things that are important. And hypothyroidism, decreased thyroxine production by the thyroid, is important. Untreated, probably everybody will have decreased thyroid function by about 10 years of age. This recent graph on the right there shows that hypothyroidism seems to occur in some children, even in this report from 2023, before 10 years of age. But I think that with good adherence to cysteamine, the need for thyroxine replacement is probably going to be in 20s or so. And of the 14 children that we've seen, only one has started thyroxine at over 30 years of age. But monitoring thyroid function is definitely necessary. The pancreas is another organ that can be affected, and certainly some of the adults that have come to the clinic are on insulin. Glucose may not be overtly high and therefore produce all the symptoms of diabetes mellitus, but blood glucose control may be impaired, and looking at hemoglobin A1C can give you an idea of the glucose control as you continue to become an adult. The transplanters know that tacrolimus and prednisone, which are used for immunosuppression, can also affect glucose control quite a lot. Eye disease, we've seen these crystals on the top right. Hopefully they're not quite as easy to see with your naked eye as that picture. But what you really don't want to see is what's depicted in the lower picture, a band of white scarring of the cornea, or keratopathy. And I think this is probably fairly unlikely if you're taking some cysteamine, but as we've heard, it's not that easy. And that glacial drop of the cyst drops, making your eye sticky, doesn't exactly encourage everybody to take eye drops very regularly. Retinal disease is probably unlikely with cysteamine treatment, but not much is published about that as far as I can see. Muscle strength. Myopathy is really difficult, and that picture of the hand shows that the muscles at the base of the thumb and all through the hand are wasted and not strong. It certainly affects the hands initially, but all muscles can be affected. And it's difficult to treat. Carnitine is lost in the urine and is increased if you give it, but whether that makes any difference to strength is not well known. Growth hormone may increase muscle bulk, which could be good. I don't know that anybody's used anabolic steroids, but if you have decreased respiratory muscles, which is certainly possible, CPAP may be needed at night. And I've started measuring muscle strength in the clinic every time I see patients, although I haven't looked across all the patients to look at the data in a systematic way yet. And there's certainly some variation. Most of the time, everybody wants to know how strong I can grip, or the parents want to know how strong they can grip as well as the kids. So it's kind of fun. Swallowing issues, another muscle issue. All these symptoms that are listed there, questions about swallowing, but it's something that comes on very gradually, so may be rather difficult to spot, can be investigated, and there are ways of having scoring systems, although I certainly don't use that. One of the problems about swallowing, reflux is also a gastrointestinal issue, and you can get recurrent aspiration, and that can cause recurrent pneumonia and other lung issues. And so paying attention to this is good. We've heard a little bit about vitamin D. Parathyroid hormone increases with decreased kidney function and is related to vitamin D use. And this causes the bone disease that Larry's just been talking a little bit about. And a couple of mentions about PTH is that if you're talking to other families, the problem is that there's various measures and the various types of assays and various units, so it's actually quite difficult to compare cross labs. But we often refer to the number of times it's increased compared to the upper limit of the reference range. Vitamin D levels can be measured too, but also need a little bit of care and interpretation because it's bound to protein, and if the protein levels in the blood are a little bit on the low side, levels of vitamin D in the blood will also be low. But supplementation, not excessive, may well be needed. Bone health. We've heard a lot about bones and the rickets that may be present at diagnosis, or often is. On the right, we've got a forearm, and the ulnar bone is a fracture. This is a patient that came to the clinic as an adult and had profound, long-standing acidosis, which is really bad for the bones. And fractures occurred in various bones, in the feet, the arms, with very little trauma because of the weakness. You can measure bone mineral density. You would have thought density would be grams per centimeter cubed, but actually it's areal density, it's grams per centimeter squared, the area of the bone that's depicted on the top there. The graph at the bottom shows that the areal bone mineral density increases with age. Actual bone density doesn't. It's an artifact of the measurement. And this is all related to growth and height. And because children and adults have lower height on average, that means that their bone mineral density will tend to be a bit on the low side, and that needs to be taken into account when interpreting bone mineral density scores. And clearly, it's related to the fracture risk, but isn't the only thing that is needs to be thought about with recurrent fractures if they occur. Knock knees. Some kids get them, some kids don't. You can do something about it, and this is a standing radiograph of someone with cystinosis and knock knees. You can see the feet are further apart than the knees, and if you pin on the inside of the knees, the growth on the outside part of the knees will straighten the legs. You can't treat this when growth has stopped, but it's actually very effective in getting rid of knock knees. Testicular function is important in boys, and it's been recognized for many years that there's hypergonadism. It's LH and FSH go up, and testosterone levels will decline. Exactly when this occurs, perhaps in the 30s or so. We have, I see some patients of 50 or so, and they're on testosterone or they have low testosterone levels. It's probably important because of bone health and muscle strength. Whether or not you need to treat those patients who have normal testosterone levels but high LH and FSH isn't well understood. So what about family life? We've heard yesterday families, adoption of children. So what about having, what about male fertility and pregnancy? Well, men with cystinosis were thought to be infertile, but a recent study of 15 showed that some had sperm in their semen. The azoospermia, no sperm in the semen, is an obstructive issue. The testes are still making sperm, and if you have a boy who's post-puberty, it may be something to talk about. It's going to be a bit difficult perhaps, but if you have sperm in the semen, perhaps some storage may be appropriate. If there's no sperm in the semen, which is probably most likely, it has been described that extraction of sperm from the testes sounds uncomfortable. It's possible with successful pregnancies. Pregnancy is also possible. It's not really known if women with cystinosis are less fertile or not, but many pregnancies have been described. And when I'm talking to someone with cystinosis and they're thinking about having a baby, the carrier frequency has been described is about 1 in 200, which means you have a 1 in 400 chance of producing a baby with cystinosis. Now, that doesn't seem very high, but it's certainly frequent enough to almost certainly justify genetic testing of a partner to look at known mutations of cystinosis to mean that the risk of producing a baby with cystinosis is very, very low. Pregnancies, mothers with cystinosis are going to be increased risk. Don't like the word high risk because it isn't really high, it's just increased from the point of view of various things. Aspirin for preeclampsia. If you have a transplant, various medications need to be stopped. And if you have your native kidneys, or if you have a transplant, stopping histamine when pregnant is advised. Certainly for the woman that has had 2 babies in our clinic, because there was increase in proteinuria, because there was a decrease in GFR after the first pregnancy, we restarted histamine at the end, towards the end of the 2nd trimester, with no apparent effect, to try and reduce the time off histamine. So I've talked a little about monitoring. There's an awful lot in those boxes in the top right-hand corner, and most of the time the results are going to be relatively good or okay. Is this all justified? Are all these tests kind of necessary? Well, I think that if you're talking about these tests and the results, you're continuing to remind people that there may be some good reasons other than the kidney, which may have been replaced with a transplant, to try and reduce or delay any of the other effects of cystinosis on the various organs. Whether this is helpful to adolescents or not, I really like the major reasons for doctors to order tests. The first one is malpractice concerns, and then there's another one saying reassure doctor. I think actually it really ought to be a little bit more patient-orientated than that. Now, doing tests, is it helpful to adolescents? Well, adolescents have this sort of unique invincibility. They don't think anything is ever going to happen bad for them. Future consequences are really not something that they're thinking about. And this is a normal phase of development and actually helps people become adults. Paul likes this slide because we've got lots of birds and bees and things like that, and the kids all have all the answers. We've got some very, very small areas, such as ability to be seen in public with parents, not very well identified. But unfortunately, the healthcare decisions haven't worked very well either, because the judgment gland and the memory to do things like chores or take your medications may not be particularly good either. This doesn't help with transition either. When we look at the process, and I'm certainly not going to go into this slide in any detail at all these facets, education, finances, support, family, and the medical system change almost all at the same time at around 18 years of age. And it's not easy. So transition in cystinosis has all the usual issues of transition to the adult system, but not many people know very much about cystinosis in the adult system, and there may be various organs, which means going to various clinics or even just different hospitals, which can be quite difficult. The adult services really need a champion, so you can actually see someone who is expecting you to support you. And there has to be some sort of role for parents as well. We don't really want them to be excluded from appointments for things like medical privacy and such like. So this transition, often the parent will step back and the adolescent will take over, but it may be a little bit more that the parent is still somewhat involved and the adolescent may actually want to have support, but it can be very successful as well. The psychosocial aspects are very significant. The social supports, medication taking, and such like can be very difficult for adults with cystinosis. And this idea of adherence means that when parents are completely in control early on, there's likely to be very little problems with adherence. Adolescents, you have to worry a lot, and adults will have some different motivations, hopefully because they want to minimize the long-term effects of cystinosis. Better information and a facilitated transition improves adherence. Kids move out and move on. I've seen people go to university, college, they rent, they buy houses, they get married. And this is really the goal of people in all society, and it can be very successful. Career choices can be difficult. You don't really want to work with something that requires a lot of strength. The tremor on various medications after a transplant could be an issue, and halitosis is also difficult. And the oldest person I've met in the clinic is a lawyer, so it's entirely possible to have very meaningful and good jobs. So I'm going to stop by saying that adult cystinosis is different but similar. There's lots of medical issues which need to be thought about, but hopefully won't be a big issue. I believe that kidney transplantation should likely be delayed until the third decade of life, and there's all sorts of problems with transition in some circumstances, but can be planned for, and hopefully the effects on life will be minimized as much as possible. Thank you.
Thank you so much, Dr. Midgley. I think we have time for one quick question. I think Dr. Midgley will be available for additional questions during the break and later on today, but does anyone have a quick question? Okay.
I think I can just talk about.
Go for it.
I'm curious when you mentioned growth hormone, is there ever been anyone, not for upward growth, but used as an antidote to muscle wasting?
Yeah, I don't know that that's been very well studied, but when growth hormone is used, it affects linear growth, but it may also affect muscle growth. And certainly I think that if families are concerned about giving an injection, say 6 or 7 times a week, if you're talking about the fact that it is good for bone health, muscle strength, muscle bulk, as well as linear growth, I think that's another issue which can encourage people to use it. I think it's very, very useful in many patients.
What about similar for testosterone?
Yeah, I think that's probably true. Paying attention to low testosterone levels and making sure that they're supplemented is probably a good thing. Again, I don't know that I can look at specific data.
Great, thank you so much.